Okay, let's unpack this. You sent in a fascinating chapter about perioperative care.
Hmm.
It's like getting a backstage pass to the world of surgery, right? Focusing on what happens before and after the actual procedure.
Exactly. Before and after. The perioperative journey.
So, we're going to dive into the key concepts of how healthcare teams collaborate and ensure patient well being during this entire journey.
Sounds good. It's a complex process, but we can break it down.
Okay, so the moment surgery is scheduled, that marks the beginning of the preoperative phase.
That's right. Instantly. It's all about getting you ready,
Yeah.
both physically and mentally.
And it's not just you and the surgeon, is it? There's a whole team involved?
Oh, absolutely. It's right then that an entire team starts to coalesce around you. You have the surgeon, obviously, but also the anesthesia provider, nurses with very specific training, surgical technicians,
All working together.
all working together. And this emphasis on interprofessional collaboration, it isn't just a nice idea.
Yeah.
It's driven by research showing that when these different roles communicate effectively, surgical errors are significantly reduced.
That makes sense.
Yeah, organizations like AON, which sets standards for surgical nursing, and IPEC, focusing on interprofessional education, they really highlight how vital this teamwork is for your safety.
Absolutely. And it goes beyond just who the people are in the room. There are actual national patient safety goals specifically related to surgery.
That's key.
We're talking about making absolutely sure it's the correct patient, the correct procedure, and the correct site on the body.
Crucial checks.
You might see site marking happening, and the team will often do a timeout right before
Yeah,
surgery.
gosh, the timeout. Yeah.
Literally, everyone stops to double check all the key information.
Exactly. And if we connect this to the bigger picture, these protocols, along with ways of communicating information like SBR, that's Situation Background Assessment Recommendation.
A structured update.
Yeah, a structured way to share updates and initiatives like SCIP, the Surgical Care Improvement Project, which focuses on preventing common surgical complications like infections and blood clots. They're all about standardizing care.
Makes it safer.
It really does.
Mhm.
Even the WHO Surgical Safety Checklist, which you might encounter, and the Team Step ES system, which gives specific tools and strategies to boost communication and teamwork skills, they all contribute to making the surgical environment as safe as possible.
So before you even get near the operating room, there's this initial assessment. Think of it as a comprehensive fact-finding mission.
That's a great way to put it. And what's insightful here is how this assessment can happen in various places for your convenience.
Oh, really? Like where?
Well, it might be in the surgeon's office during a pre-admission visit if you're already in the hospital, maybe even over the phone or online sometimes.
Okay.
But regardless of where it takes place, keeping your information private is a huge priority, so you feel comfortable sharing everything the team needs to know.
And it really is comprehensive, isn't it? They're going to ask about everything.
Pretty much everything, yeah.
Starting with your age and general health, then go through a review of all your body systems, asking about things like any heart issues, lung problems, digestion, and so on. Box 9.3 in this chapter gives a good overview of those questions.
Right. And this review of systems, while it might seem like a lot of questions, is absolutely critical for identifying any potential risks you might have.
Mm.
If we connect this to the bigger picture, knowing about any existing medical conditions like chronic illnesses, maybe diabetes or heart disease, helps the surgical team anticipate potential complications.
And tailor the care.
Exactly. Tailor your care to your specific needs. They'll also want to know about any current problems you're being treated for.
And don't forget allergies. That's always a big one.
Huge. They'll ask about medications, of course, but also things like latex sensitivity.
Right. And what about prostheses? I saw a note about that.
Yes. They'll want to know if you have any prostheses.
Hmm.
There's a specific warning about electrocautery pads needing to be placed away from those areas to prevent burns.
Good to know. And your surgical history is important too, right? How you handled things before.
Definitely. How you tolerated previous procedures and anesthesia gives them really valuable clues.
It's really insightful how much detail they go into.
It is.
Yeah.
Even your social history, things like whether you use tobacco, alcohol, or any other substances,
Yeah,
that can impact how your body responds to surgery and anesthesia.
makes sense.
They'll also ask about all the medications you're currently taking, including over-the-counter drugs and any herbal supplements.
Because of interactions.
Precisely. Because these can sometimes interact with anesthesia or other medications used during surgery.
Family history is another piece of the puzzle then.
It is. They'll be looking for things like a family history of malignant hyperthermia. We can talk more about that later. Or cancer, bleeding disorders.
Or bad reactions to anesthesia in the family.
Exactly. If anyone in your family has had reactions or complications with anesthesia, then there's the psychosocial aspect.
What does that cover?
Well, how much you understand about the surgery, your comfort level, the support system you have in place. They might also ask about cultural or spiritual needs and your preferences regarding blood donations.
That really highlights that patient-centered approach they aim for.
It does. The psychosocial assessment recognizes that surgery isn't just a physical event. It has a significant emotional and social side, too.
So understanding how much you know, how you feel, the support you have, it helps them care for the whole person.
That's the goal. And the questions about blood donation, whether you'd consider donating your own blood beforehand, that's autologous.
Or having family donate.
Right, directed donation from family or friends, or if you have any interest in bloodless surgery techniques, it shows they're trying to respect your individual beliefs and preferences.
They also use something called the ASA Physical Status Classification System. I saw that in Table 9.3. What's that for?
Ah, the ASA classification. It's basically a shorthand way for the anesthesia provider to communicate your overall health status before surgery.
Like a quick rating.
Sort of. They assign you to one of several categories based on any existing medical conditions you have. It helps the whole team quickly grasp your risk level.
Okay.
And interestingly, what we're seeing is a trend of more patients presenting with higher ASA classifications, maybe due to more chronic conditions in the population, which means even more careful preoperative planning is often needed.
So speaking of risks, there are definitely some specific ones they'll be paying close attention to. Cardiac problems are a big one.
The very big one. Things like coronary artery disease, angina, a recent heart attack, especially within 6 months, heart failure, high blood pressure, irregular heart rhythms, they all increase risk.
And I noticed they mention if you're on beta blockers for a heart condition, you should usually keep taking them.
Yes, that's a key point. Suddenly stopping certain heart medications can actually be more dangerous than continuing them. Yeah. Continuing beta blockers, for instance, can help keep your blood pressure and heart rate stable during the stress of surgery. The chapter emphasizes that pre-existing heart problems can make it harder for your body to handle the changes during and after surgery.
Okay. What about lung issues?
Pulmonary problems are another area of focus, especially for older adults, people with chronic lung conditions like asthma or COPD, and smokers.
Smoking, yeah. That always comes up.
It does. As we know, smoking damages your lungs and can increase the risk of complications like pneumonia and atelectasis. That's when parts of the lung collapse.
And it affects oxygen.
Right. It increases carboxyhemoglobin levels, which reduces how much oxygen your blood can carry. Plus, it impairs the cilia, those tiny hairs in your lungs that clear mucus. So breathing can be tougher after surgery.
Then there's malignant hyperthermia, MH. You mentioned that briefly. It's inherited.
Yes, it's an inherited muscle disorder. It's a rare but very serious reaction to certain anesthesia drugs. They'll definitely ask if you or anyone in your family has ever had it.
What are the signs?
The earliest signs can be subtle: a rise in the carbon dioxide you breathe out, maybe a drop in oxygen levels, a fast heart rate. Muscle rigidity is a big one too. A really high fever is actually a later sign.
Is there a treatment?
Yes, thankfully. There's a specific drug called dantrolene sodium, and there are tests, a genetic test and a muscle biopsy test called CHCT to check for susceptibility beforehand.
Given how rare it is, why is it given so much attention in the preoperative assessment?
That's a good question. Even though MH is rare, it's potentially fatal, and it develops fast. So early recognition is absolutely crucial.
And the family history helps identify risk.
Exactly.
Yeah.
Plus, knowing there's a specific treatment like dantrolene makes identifying those at risk even more important.
Older adults also have some unique risks, right? Table 9.4 mentioned things like immune function, healing.
That's right. Decreased immune function, delayed healing, a higher chance of having chronic illnesses, changes in gas exchange, and slower elimination of medications. These can all affect how older adults respond to surgery.
They just have less reserve.
Pretty much. Age-related changes mean organ systems might be more vulnerable to stress. The chapter also notes things like malnutrition and dehydration can be more common too, complicating recovery.
Okay. Let's go back to allergies for a second. Medications, latex. What about food?
Good point. They'll ask about food allergies too. And it's interesting, that old idea about shellfish allergy and iodine, that's largely debunked.
Oh, okay.
The shellfish allergy is to a protein, not the iodine itself. However, some connections are real. If you're allergic to things like avocados, bananas, or strawberries,
You might react to latex.
you might have a latex sensitivity, yes. And allergies to egg, peanut, or soy could mean a risk of reaction to propofol, a common anesthetic.
Wow. So it's really important to tell them everything.
Everything. Clearly communicating any allergies to everyone on the team is essential. Understanding those potential cross-reactivities helps them choose the safest options for you.
And what about blood? You mentioned donation preferences earlier.
Right. They might discuss blood donation options. You can donate your own blood before surgery. That's autologous donation.
Or have family donate.
Sometimes family or friends can donate specifically for you, which is directed donation. And there are also bloodless surgery techniques.
What does that involve?
Techniques that aim to minimize blood loss, like using cell saver machines to collect and return your own blood during surgery, limiting blood samples taken, maybe using meds like Epoetin alpha to boost red blood cells beforehand.
So several options depending on the situation and your preferences.
Exactly. These strategies reflect a move towards minimizing transfusions and respecting your wishes. Autologous donation avoids transfusion reactions, and cell salvage is great for surgeries with expected high blood loss.
It's interesting that discharge planning actually starts way before the surgery.
It does. They'll be thinking about your home environment, your ability to care for yourself after surgery, and the support systems you have in place.
To figure out what you might need when you go home.
Precisely. It's not something tacked on at the end. Assessing your needs early helps ensure a smoother transition home and can actually help reduce the risk of problems after surgery or needing to be readmitted.
Okay, so after all the questions, there's the physical assessment, vital signs, obviously.
Yep. Establishing that baseline is crucial for comparison later.
And they really focus on the cardiovascular system, checking blood pressure, listening to the heart.
Absolutely. Checking for high blood pressure, listening for abnormal heart sounds, asking about any history of blood clots. They'll also check pulses in your hands and feet and look for swelling or edema.
And pacemakers.
Need to know about those too, yes. Any implantable devices. It all helps identify conditions needing special attention.
Then the respiratory system, looking at breathing effort, rate, listening to lungs.
Right. Asking about smoking, checking for sleep apnea, obesity can be a risk factor there. Things like finger clubbing or a bluish skin tint can also give clues about oxygen levels.
Why is this so important?
Because anesthesia and pain meds can affect breathing after surgery. Identifying risks beforehand lets the team plan ways to help you breathe effectively post-op and prevent complications.
Kidney function, too, affects medications.
Big time. Kidneys process meds and waste.
Mm-hmm.
So they might ask about urination patterns, pain, output. Good kidney function means meds get eliminated properly.
Neurologic status is checked, too. Alertness, orientation.
Yep. Mental status, are you alert, oriented, level of consciousness, ability to follow commands. Also looking for weakness, numbness, checking your gait and balance to assess fall risk.
So they have a baseline before anesthesia.
Exactly. And evaluating fall risk helps keep you safe during recovery.
What about musculoskeletal issues, like arthritis?
That can impact positioning during and after surgery. They'll note things like arthritis or any unique anatomical features to keep you comfortable and prevent injury.
And nutrition, being underweight or overweight matters.
It really does. Both can increase surgical risks and affect healing. They might look for physical signs, brittle nails, muscle wasting changes, check blood pressure changes when standing, and review certain blood tests.
Because surgery increases the body's needs.
Right. Your body needs more energy and nutrients to heal, and if you don't have enough reserves, it slows things down.
Finally, the skin assessment. Looking for breakdown, piercings, tattoos.
Yes, checking skin color, turgor, temperature, any existing breakdown or lesions, noting pressure points. Piercings and tattoos might need consideration during the procedure too.
And then there's the psychosocial assessment again, focusing on anxiety and fear.
Right. Trying to understand your anxiety levels. Signs like restlessness, faster heart rate, sweating, trouble sleeping can indicate anxiety.
And they ask about coping mechanisms, support systems.
Yes. How you usually cope with stress, who your support people are. It's all about building that complete picture, physical, emotional, social support, to tailor support and make you as comfortable as possible.
Okay, that's a lot of assessment. What about lab tests?
There's usually a standard battery before surgery. Things like a urinalysis, blood type and screen, a complete blood count, or CBC.
Clotting studies.
Yep, clotting studies, a metabolic panel which checks electrolytes and kidney liver function, and often a pregnancy test for women of childbearing age.
What are they looking for?
Any abnormal results, really, like imbalances in electrolytes. Potassium is especially important for heart function, signs of infection, anemia, clotting problems, things that might need addressing before surgery.
So these lab tests, What are the key categories of things the surgical team is trying to understand about my body before surgery?
That's a good way to think about it. Primarily, they want to assess your overall health, check major organ function like kidneys and liver, look at your blood health cell counts, clotting ability, and spot any issues like infections or electrolyte imbalances that need sorting out first.
And sometimes imaging, like a chest x-ray.
Depending on your medical history, yes. A chest x-ray is common, especially with a history of respiratory problems, to check for things like pneumonia.
Or other scans.
Other imaging, like CT or MRI, might be needed for specific surgeries, like before spinal surgery, to get a detailed look.
Okay. And an ECG for the heart.
An electrocardiogram, or ECG, might be required, especially with a heart history, or over a certain age, maybe 40 or 45, particularly for general anesthesia.
Gives a baseline reading.
Exactly. It helps get a baseline of your heart's electrical activity and identify existing issues. They might even get a cardiology consult or prescribe preventative meds like nitroglycerin or beta blockers for some patients.
So, with all that assessment done, the big priorities become health teaching and managing anxiety.
Those are definitely two major collaborative problems they identify. Making sure you understand what's happening and addressing your anxieties are fundamental.
Better experience, better recovery.
Pretty much. When you understand and feel less anxious, you tend to participate more in your care and recover better.
Which leads us to the planning and implementation phase. Lots of health teaching involved here.
A huge part. There are even guidelines like the ERA Society Enhanced Recovery. After surgery, focused on best practices to help patients recover faster with fewer bumps.
How do they teach?
They'll see what you already know, figure out how you learn best pamphlets, websites, videos, maybe classes or tours. And if you're having outpatient sedation, they'll really stress having a responsible adult drive you home.
Critical safety measure.
Absolutely. Don't want any accidents if you're still groggy.
Then there's ensuring informed consent. That sounds really important, legally and ethically.
It's essential. The surgeon has to explain everything the procedure, who's doing it, options, risks, anesthesia risks, blood product risks, and benefits.
And the nurse's role?
The nurse often witnesses your signature, helps clarify information the surgeon provided, make sure you don't have major misunderstandings. They act as your advocate.
And you can always say no.
Absolutely. You have the right to refuse treatment, even if the team thinks it might negatively affect your health. It's about respecting your autonomy.
What if someone can't sign? Like physically unable?
They can sign with an X, but that needs two witnesses. If someone can't consent and doesn't have a medical power of attorney, a legal guardian might need to step in.
Emergencies.
In emergencies, they try to consult with at least two other providers. For blind patients, two witnesses are usually needed.
Language barriers.
A qualified medical translator is essential. They generally discourage using family members to avoid potential misunderstandings or pressure.
Okay. And special consents for some things.
Yes, things like sterilization, experimental treatments, anesthesia itself. Blood products often have separate consent forms.
And site marking. The surgeon does that.
Yes, the surgeon personally marks the surgical site with you, outside the operating room, before you get any sedation. It's a key safety check.
What about advanced directives, like a living will? Do those still apply during surgery?
Absolutely. Any advanced directives you have remain valid and should be respected. They guide the team if you become unable to make decisions.
Okay. Then dietary restrictions. NPO, nothing by mouth. Why is that so strict?
It's all about reducing the risk of aspiration stomach contents getting into your lungs during anesthesia. An empty stomach is much safer.
How long before surgery?
It varies. Generally, no heavy meals within 8 hours, lighter food maybe 6 hours, clear liquids usually okay up to 2 hours before, but you must follow the specific instructions you're given.
Or surgery could be delayed?
Or even canceled, unfortunately. It's that important for safety. Sometimes a clear liquid carb drink might be ordered a couple of hours before for non-diabetics, but the evidence is still mixed. Diabetic patients get very specific guidance.
What about regular medications on surgery day?
You definitely need to discuss those with your surgeon and anesthesia provider. Some meds might be okay with a tiny sip of water. Others need to be held.
Like blood pressure pills, diabetes meds.
Exactly. There are specific guidelines, especially for diabetes meds, to keep blood sugar stable. Sometimes beta blockers might even be started on surgery day for high-risk patients, even if they don't usually take them.
So careful management is key.
Essential to prevent unwanted interactions or problems during surgery.
For some surgeries, especially bowel surgery, you might need intestinal prep, laxatives or enemas.
Yes, to empty the bowels. It reduces infection risk and helps the surgeon see better.
Any side effects to watch for?
It can sometimes cause temporary electrolyte imbalances or dehydration, maybe make you feel dizzy. So they'll remind you to call for help getting up to prevent falls.
Skin preparation is another step, right? To prevent
A
infection.
very important one. You might be asked to shower with a special antiseptic soap, like chlorhexidine gluconate, for a day or two beforehand.
What about hair removal?
If it's necessary at the site, they prefer using clippers or depilatory cream right before surgery. Shaving can create tiny nicks that increase infection risk.
Okay.
Sometimes for specific surgeries, they might even use a nasal ointment, like mupirocin, to reduce bacteria there.
They also prepare you for tubes and drains you might have after surgery.
Yes, explaining things like NG tubes, urinary catheters, or surgical drains beforehand helps reduce anxiety. Knowing what they're for makes it less scary.
And the IV line?
They explain that's for fluids and medications. It's all about demystifying the process.
And they teach you exercises for after surgery, beforehand.
Yes. Things like deep breathing, using an incentive spirometer to expand your lungs, how to cough effectively while splinting your incision.
Splinting, like holding a pillow.
Exactly. Holding a pillow over the incision for support when you cough.
Hmm.
Also, leg exercises to prevent blood clots. And they stress getting up and moving as soon as possible.
Learning it beforehand helps you do it right afterward.
Definitely. You can practice and be ready. Early ambulation walking is one of the best things for recovery.
Minimizing anxiety is also a focus. How do they help with that?
By assessing your anxiety level, providing clear information, answering all your questions, encouraging you to talk about concerns. Promoting rest is important too. Maybe relaxation techniques, sometimes a mild sedative the night before,
Distraction helps too.
can do. Reading, talking with family. They'll also keep your family informed with your permission about timing and where to wait.
That communication must help a lot.
It really does. Feeling informed and supported reduces uncertainty and fear.
Before you actually go to the surgical suite, there's a final check of everything.
Yes, a final review of your electronic health record, making sure all documentation is complete, consent signed, site marked, allergies noted, recent labs and vitals are there.
Like a pre-flight checklist.
Exactly. A crucial safety check to ensure all essential info is available and correct before takeoff, so to speak.
And getting ready to go, removing clothes, putting on a gown.
Right. Maybe anti-embolism stockings or compression devices in order to prevent clots, valuables secured, jewelry off.
Dentures, glasses.
Dentures might need removal depending on anesthesia. Glasses and hearing aids often stay until just before. Prosthetics, contacts, wigs, hairpins all need to come off for safety.
Nail polish.
Can interfere with the pulse oximeter, so usually removed. And emptying your bladder right before you go.
And sometimes pre-op meds, like antibiotics.
Yes, if you're already hospitalized, you might get some meds in the pre-op area. Prophylactic antibiotics are often given shortly before surgery starts to prevent infection.
Then the actual transfer to the surgical suite, another review.
One last review of the chart, reinforcing instructions, checking attire, giving any remaining pre-op meds. They use a checklist.
To make sure nothing's missed.
Exactly. Then transport, usually on a stretcher for safety and comfort. It's a very carefully coordinated handoff.
So how do we know if all this preoperative care worked? What are the goals?
Good question. We evaluate outcomes. Did you understand the consent and procedures? Can you demonstrate the exercises? Do you report feeling less anxious?
So a well-prepared, informed, less anxious patient is the goal.
That's it. That sets the stage for a better surgical experience and smoother recovery.
Okay, now the surgery's over. The postoperative phase begins, and the focus shifts to monitoring and recovery.
Right. And what's really critical here is that immediate transition into a specialized care environment, usually the PCU, post-anesthesia care unit,
Or ICU sometimes.
or ICU, yeah, depending on the surgery's complexity and your condition. The immediate hours after surgery sound incredibly critical. What are the absolute top priorities in that PCU environment, and how does that initial focus transition as I move to a regular unit?
Good question. There are actually different phases of post-anesthesia care. Phase I is right there in the PCU or ICU. Very frequent, close monitoring until you're stable.
Okay, phase 1, intense monitoring.
Then phase 2, that's about preparing you for extended care, maybe on a regular hospital unit, or even getting ready for discharge home if it was outpatient surgery. You're more awake, vital stable.
Getting ready for the next step.
And phase 3 is that longer-term recovery, either still in the hospital or at home. Less frequent monitoring, but still recovering. Ambulatory surgery patients might move through these phases much faster.
So the phases reflect the level of support needed as you recover. Phase I stabilizes immediate needs, breathing, circulation, consciousness. Phase 2 gets you more awake and comfortable. Phase 3 is continuing recovery.
Makes sense. And before you even leave the OR, there's a crucial handoff report.
Absolutely critical. From the operating room team anesthesia provider, circulating nurse to the PCU nurse taking over immediate care.
And another handoff when moving from PCU to the regular unit.
Yes. Box 9.7 gives an idea of the detailed shared specifics of the surgery, anesthesia type, allergies, intra-op condition, fluids given, drains, etc.
So everyone stays informed.
Essential for safety and continuity. The receiving nurse gets complete picture to anticipate needs and provide the right care. No gaps.
And the PCU nurse needs specialized skills.
Oh, yeah. Managing airways, breathing, pain right after anesthesia, responding quickly to emergencies. They're monitoring you almost constantly, communicating with the surgeon and anesthesia team.
Vigilant care.
Absolutely vital for that initial recovery.
Once you get to the medical surgical unit, the nurse there uses all that info.
Yes, uses the surgical and PCU reports, reviews your pre-op assessment in the chart, and develops your ongoing care plan. They're also watching for potential postoperative complications listed in Box 9.8.
Continuing the monitoring.
Exactly. Building on the PCU care, addressing ongoing needs, and watching for any problems early.
What's the very first assessment on that unit?
Checking for stable vital signs, blood pressure, heart rate, breathing, temp. Making sure you're alert, no obvious bleeding from the site, reflexes returned.
Able to drink? Urinating?
Yes, checking if you can tolerate liquids and if you're producing urine. And really closely monitoring breathing and oxygen levels, especially after anesthesia, sedation, or opioids.
That respiratory monitoring seems like a top priority.
It absolutely is.
Yeah.
Anesthesia and some meds can depress breathing, so it needs close watch.
There's a critical rescue warning in the chapter about serious risks.
Yes, reminding us all post-op patients are potentially at risk for things like pneumonia, shock, cardiac or respiratory arrest, blood clots, VTE, and GI bleeding.
So signs of those need immediate action.
Immediate notification of the surgeon. Early recognition and prompt intervention are crucial.
They'll do a full assessment once you're settled, checking everything again.
Yep. Level of consciousness. O2 saturation with the pulse oximeter, checking the surgical area for bleeding infection, taking vital signs frequently based on policy, orders, and your condition.
Tailored to you.
Exactly. It provides a detailed picture of your status and tracks progress.
Okay, let's go system by system post-op. Respiratory first, ensuring a clear airway.
Right. And just talking doesn't guarantee it's fully open. Checking any artificial airways, oxygen delivery details. Continuously monitoring O2 sats, aiming above 95%.
Listening to lungs frequently.
At least every 4 hours for the first 24 hours, then typically every 8. More often for higher-risk patients, older adults, smokers, lung disease, obesity.
And a drop in O2 sats is serious.
That's a critical rescue.
Yeah.
Immediate attention needed. They also watch breathing rate, pattern, depth. Listen for sounds like snoring or stridor indicating obstruction. And watch for lingering muscle relaxant effects causing weakness.
So thorough checks to make sure gas exchange is happening.
Essential. Detecting breathing problems early is critical.
Cardiovascular next. Watching vital sign trends.
Comparing them to your pre-op baseline. Big changes in BP or heart rate could mean cardiac issues, fluid loss, shock, drug effects.
Slow heart rate, fast heart rate.
Bradycardia, a slow rate, might be anesthesia or hypothermia, especially in older adults. Tachycardia, fast rate, could be hemorrhage, shock, or just pain.
Heart monitor maybe. Comparing pulses.
Might be on a monitor. Comparing apical pulse in the chest to peripheral pulses helps spot dysrhythmias, and they do a peripheral vascular assessment daily.
Checking feet and legs. Pulses, color, temp.
Sensation, movement, capillary refill, making sure blood flow is good. And VTE prevention is huge.
Blood clots. Pulmonary embolism risk.
Yes, PE is a leading cause of preventable in-hospital death. So assessing your risk and using prophylaxis is standard.
Like compression stockings, pneumatic devices.
Exactly. TED stockings, pneumatic compression devices that squeeze the legs, sometimes blood thinners. The Action Alert emphasizes VTE risk assessment and prevention for everyone. They ensure devices fit right and check skin regularly.
Neurologically, checking consciousness orientation.
Cerebral function, level of consciousness alert, restless, confused, oriented to person, place, time, situation, observing how you wake up from anesthesia.
Older adults might take longer.
Often do. The chapter has good patient-centered care tips, ensuring glass hearing aids are available, encouraging early movement, managing pain sleep well to help them reorient and prevent delirium.
Comparing pre-op and post-op mental status is key.
Regularly, yeah. Every
Yeah.
4 to 8 hours. Preventing post-op delirium, especially in older adults, is a big focus. They might use screening tools and preventive strategies,
Also checking motor and sensory function, movement and feeling.
especially after general or regional anesthesia. Testing sensation, asking you to move extremities, checking strength. If you had spinal or epidural, watching for specific complications listed in box 9.0: breathing issues, low BP, hematoma, infection, headache.
Lots to monitor there. What about fluid and electrolyte balance?
That's carefully watched too. Being NPO, fluid loss during surgery. IV fluids given all can affect the balance. Watching for dehydration or overload. Checking electrolyte levels, sodium, potassium, chloride, calcium, especially in older adults or those with chronic conditions.
Crapping intake and output.
Meticulously.
Mm-hmm.
5E fluids, urine output, drain output.
Yeah.
Assessing hydration, checking mouth moisture, skin turgor. Comparing intake versus output, considering insensible losses like sweat. Monitoring 5 fluids, adjusting type as needed.
And acid-base balance.
Can be affected by breathing status, metabolic changes, fluid losses like from an NG tube or vomiting. They might check ABGs or other labs.
Kidneys and urinary system watching for difficulty urinating.
Yes, retention can happen after anesthesia or certain drugs.
Yeah.
They assess a bladder distension, maybe use a bladder scanner. If you have a catheter, they monitor urine color, clarity, amount.
If you're voiding on your own.
They track frequency, amount, any symptoms,
Yeah.
aiming for output close to intake. Low output, like less than 30 LAI, is concerning, could be dehydration or kidney issues.
Gastrointestinal system nausea and vomiting are common. PONV.
Unfortunately, yes. Especially with general anesthesia, motion sickness history, obesity, abdominal surgery, opioids. They might give anti-nausea meds preventatively.
Why is PONV a concern?
Puts stress on wounds, increases pressures, risk of aspiration. They assess for it. Might suggest positioning changes like side-lying first.
And waiting for bowel function to return? Peristalsis?
Yep. Listening for bowel sounds, asking about passing gas or stool, those are key indicators. Things are moving again. Cramping or distension might mean trapped gas.
What's paralytic ileus?
That's when the bowel temporarily stops working altogether. If you have an NG tube, it might be for decompression. They monitor NG drainage color, amount, consistency, check for blood.
Important note about NG tubes after stomach surgery?
Action alert. No manipulating or irrigating unless specifically ordered by the surgeon.
Constipation is also a risk.
Common due to anesthesia, opioids, less activity in intake. They assess the abdomen, ask about elimination, might suggest fiber, laxatives, enemas, and definitely early ambulation helps.
Integumentary system, the skin and wound. How's healing assessed?
A clean wound surface heals in about 2 weeks, but full healing takes much longer, months even. Factors like age, obesity, immune status, diabetes, smoking can delay it.
What do they look for at the incision?
Assess Q8 for redness, warmth, swelling, tenderness, drainage, tight mount. Some drainage is normal initially, bloody to serosanguineous to serous.
What are warning signs?
Serosanguineous drainage beyond day 5 or increasing amount could signal dehiscence risk. Significant redness, swelling, excessive pain, or purulent odorous drainage suggests infection, SSI.
Dehiscence, evisceration, those sound serious.
They are. Dehiscence is partial wound separation. Evisceration is total separation with organs protruding, a surgical emergency. Risk factors include diabetes, obesity, poor nutrition, steroids. Often happens day 5-10 after forceful coughing straining. Patient might report a popping feeling.
How are dressings and drains managed?
Assess all dressings on admission and routinely Q8O for bleeding drainage amount, color, consistency, odor. Mark drainage spread. Check underneath patient. Ensure dressing isn't restricting circulation breathing.
And drains.
Placed for expected drainage. Penrose drains are open, gravity fed, drain onto dressing, need a safety pin. Closed suction drains, JPM vac, have a reservoir. Minimal dressing drainage, needs suction checked, sutured in place.
Pain assessment is ongoing.
Continuous, subjective. Ask using 0-10 scale. Look for physical behavioral signs, increased vitals, sweating, restlessness, wincing, moaning. Assess before-after meds. Plan activities around analgesia. Reassess effectiveness. Document everything.
Special considerations for older adults and pain.
Pain can be underassessed. Communication issues, other conditions, stoicism might lead to underreporting. Need to watch nonverbal cues closely. Adjust dosages carefully.
Psychosocial assessment continues post-op too.
Yes. Looking for anxiety signs, addressing questions about results, reinforcing surgeon's info, assessing family caregiver comfort and support needs too, preparing for social service referrals if needed.
And follow-up lab tests.
Based on procedure, history, symptoms. Electrolytes, CBC, common. Changes often seen first, 24-48 due to fluid shifts. Watching for signs of infection like a left shift in white blood cells. Get cultures if infection is suspected. ABGs for respiratory cardiac patients. Notify surgeon of significant results.
So the big priority collaborative problems post-op are decreased gas exchange,
Risk of infection or delayed healing.
acute pain,
Increased peristalsis.
and potential for bleeding or hemorrhage.
Exactly. The care plan focuses on preventing or managing these.
For improving gas exchange, monitoring O2 sats is key.
Continuously with vitals or hourly initially. Highest risk is often day 2. Might give low-dose O2, especially for older adults. Positioning helps semi-foulers or side-lying.
And breathing exercises.
Crucial. Coughing, instead of spirometer hourly while awake, splinting incision, suctioning if needed, and movement. Early ambulation is huge for preventing lung issues and clots. If not possible, turn Q2H, do exercises in bed.
For preventing wound infection and promoting healing, wound care focus.
Meticulous wound care. Reinforce change dressings, assess healing infection, manage drains. Empty, measure, document. Encourage hip bending when supine to reduce tension. Always splint when coughing. Follow skincare best practices for older adults.
Dressing types vary. Surgeon does first change.
Yes, dressings vary. Surgeon usually does first change. Nurses follow policy orders after, assess site Q8, report unexpected findings, use aseptic technique until suture staples out, offer pain meds before big changes drain removal.
Suture staple removal.
By surgeon or trained nurse, usually day 5, 10, sometimes longer. Clean first, maybe remove every other. Reassess. Notify surgeon if not healing well before removing. Might apply closure tape after.
Drain management. Penrose versus J-Fimovac.
Penrose is open, drains to dressing, secured with pin, advanced as drainage slows. J-Fimovac are closed suction, sutured reservoir emptied Q-shift, suction restored, secured to gown.
Antibiotics. Other treatments.
Prophylactic antibiotics before, during. Reevaluate at 24-hour. Continue with infection signs. Infected wounds need dressings. Systemic antibiotics, maybe irrigation packing, NPWT. Sometimes surgical management needed.
What about managing dehiscence?
Apply sterile, non-adherent saline dressing. Notify surgeon, bend knees, avoid coughing. Infected wounds might dehisce or be open for IND.
And evisceration. The emergency.
Surgical emergency.
Yeah.
Box 9.13 details. Call for help, reassure patient, position supine with knee ships bent, head slightly elevated, 15 to 20 degrees. Cover organs with sterile, warm saline dressings, waterproof drape. Do not reinsert organs. Assess for shock. Frequent vitals. Keep dressings moist. Report to surgeon RRT. Prep for surgery. NPO.
Prevention is best. Nutrition matters.
Hugely. Encourage protein, vitamins, calories for at-risk patients. Monitor intake, involve RDN. And G-tube might be needed pre-repair for evisceration. Maybe regional local anesthesia for repair. State sutures might be used.
Managing pain combination approach.
Often best. Meds and non-drug methods. Assess pain and effectiveness. Good control helps cooperation.
Drug therapy. Opioids initially. PCA.
Opioids, common first, 24-48-0. PCA allows self-administration within limits. Transition to oral meds is tolerated. Common drugs. Morphine, hydromorphone, note potency difference, ketorolac, codeine, etc. Maybe anti-anxiety adjuncts.
Monitoring after opioids is crucial.
Yes. Assess pain before-after meds using scale. Monitor vitals for low BP, slow breathing. Avoid over-under medication, especially in older adults. Watch LOC. Have naloxone ready for reversal if needed.
PCA use in older adults.
Ensure they understand. Reassure about safety features. Monitor vitals frequently after naloxone. Short duration, might need repeats. Assess for breakthrough pain. Offer ordered meds if pain persists after checking vitals. Gradually reduce doses.
Non-opioids too.
Acetaminophen. NSAIDs alone or with opioids. And remember that action alert. Avoid pillows under knees-raising knee gauge increases VTE risk.
Non-drug methods. Massage.
Gentle massage, not on your site. Positioning, maybe lotion. Avoid calf massage due to PE risk.
And finally, managing decreased paracelsus. The goal is just getting things moving again.
That's the expected outcome, yes.
Mm.
Return of normal intestinal movement. Early ambulation, managing pain meds. Sometimes specific meds can help.
So as you can see, the journey through surgery is a carefully orchestrated process with a multitude of considerations at each stage, all focused on your safety and recovery. From the initial assessments and meticulous preparations to the vigilant monitoring and pain management after the procedure, every step is designed with specific goals in mind.
What's truly insightful here, I think, is how interconnected all of these elements are.
Yeah.
You know, the detailed information gathered during your preoperative assessment directly informs the care you receive both during and after the surgery.
Right.
And the constant focus on clear communication and effective teamwork really underscores the complexity and the highly collaborative nature of modern medicine. It's quite amazing.
Hopefully this deep dive has given you, our listener, a much clearer picture of what to expect should you or a loved one ever face surgery. Remember, your healthcare team is there to guide you and support you every step of the way.
Definitely. And considering the incredible advancements in surgical care and the level of detailed planning and coordination involved, what other areas of healthcare do you think might benefit most from a similar proactive and patient-centered approach to care? Something to think about.
That's a great question to leave folks with. Thank you so much for sharing your curiosity with us. If you have any more questions or other topics you'd be interested in us exploring in future deep dives, please don't hesitate to let us know.